I'm Dr. Fakir Abari, and this is Human Immunodeficiency Virus in Adults Part 2. Here are the reliable resources for this topic. In particular, we are going to cover the 2021 CDC guidelines for pre-exposure prophylaxis for the prevention of HIV infection, which was updated in 2025 to add recommendations regarding injectable lenacapavir as HIV PrEP. We will also cover post-exposure prophylaxis. In particular, there are two guidelines: post-exposure prophylaxis in healthcare settings. This is occupational post-exposure prophylaxis. There's also non-occupational post-exposure, and the recommendations are similar between the two. The next learning objective is: given a patient at risk for exposure to HIV, recommend appropriate PrEP regimen. The 2021 guidelines for PrEP recommend that all sexually active patients should receive information about pre-exposure prophylaxis or PrEP. And of course, the ultimate goal of PrEP is to prevent the acquisition of HIV infection, along with its morbidity, mortality, and cost to individuals as well as society. PrEP is recommended for individuals who are at ongoing risk for HIV exposure, either from sexual behaviors or in individuals who inject drugs if they report injection practices that place them at risk. Now, one thing that is important is that acute and chronic HIV infection must be excluded by symptom history and HIV testing immediately before any pre-exposure prophylaxis regimen is prescribed. So let's take a look at how to exclude HIV. So clinicians should document a negative antibody test result within the 7 days before initiating PrEP. And this should be done ideally with an antigen antibody test. And it must be from the blood. So there should be a blood or serum sample. And it is preferred to have an antigen antibody test that's done in the laboratory. And that if that's not available, then a point of care antigen antibody test can be done still on the blood. Now, I emphasize that the sample needs to be from the blood because rapid tests that use oral fluids should not be used, specifically because they can be less sensitive than blood tests. So there would be high risk of false negative. The guidelines also state that clinicians should not accept patient-reported test results or documented anonymous test results. Now, let's take a look at the algorithm that's in the guidelines. So this is for people who are not on pre-exposure prophylaxis or any prophylaxis, including post-exposure prophylaxis. So for someone who is about to be initiated for the first time on PrEP, the antibody antigen test is preferred from the blood. And then if the results are positive, of course, this is considered HIV positive, and then they will be excluded from being initiated on pre-exposure prophylaxis. And then if in fact this is confirmed to be a true positive, then they need to be transitioned into treatment of HIV. Now, for individuals where they either test negative or if there is indeterminate test, the next thing to consider is if they have had HIV exposure in the past 4 weeks, and if they have signs and symptoms of acute HIV infection. If the answer is no, because the results are either negative or indeterminate, it's safe to assume the patient does not have HIV, and it will be safe for them to initiate PrEP. Now, if the answer to this question is yes, a second test needs to be done from the plasma to confirm the results. So this can be either another antibody antigen assay, or it could be an RNA assay, HIV-1 RNA assay. And of course, if either of these are positive, the patient is HIV positive. If either of them are negative, it would be HIV negative, and then the patient can be started on PrEP. Now, for the RNA assay, the level that would be significant would be 200 copies per ml. So if the level is less than 200 copies, for example, if it's 150, it could potentially be a false positive. So it is recommended to get another level and find out, if that's a false positive or negative. But in general, if it's at least 200 copies or higher, it's considered a positive result. Now, here are the CDC recommendations for HIV pre-exposure prophylaxis that were released in 2021, and then they were updated in 2025 to add the lenacapavir to the recommendations. In general, we can think of 3 groups of people who qualify for pre-exposure prophylaxis. So men having sex with men or transgender women. The second group is heterosexual men and women. The third group is persons who inject drugs. And of course, we don't have data on pre-exposure prophylaxis in transgender men, and that's why they're not included in these recommendations. And then we can think of oral regimens and then injectable regimens. So the oral regimens, which should be dispensed in 90-day supplies, that way people will come back every 3 months for assessment and monitoring. Essentially, we have emtricitabine TDF daily or emtricitabine TAF daily. That's 1 pill once a day for MSM and transgender women. For heterosexual men and women, TAF has not been approved, so we only have emtricitabine TDF as oral daily regimen, and the same thing for persons who inject drugs. So TAF is not effective for these 2 groups, only for MSM and transgender women. For injection agents, we have cabotegravir, which is an intramuscular injection. It's in the gluteal muscle, so it is done in the clinic. For the initial dose, 600 milligram. Second dose is 4 weeks later, and then after that, starting from the third dose, it's going to be every 8 weeks, so approximately every 2 months. So that's good for adherence. We also have lenacapavir, which is the most recent one. This is a subcutaneous injection. This one, interestingly, has also a loading dose of oral lenacapavir for the first 2 days. So on day 1 and day 2, patients will receive an oral. These are actually a couple of pills each on day 1 and day 2. And then after that, it's an injectable every 6 months. So essentially 2 injections per year, which will really improve adherence. Now you can choose either injection or oral regimen, not both at the same time. And here are the criteria for identifying patients who qualify. So for the first 2 groups, if people have anal or vaginal sex in the past 6 months, and if they meet any of the following, either HIV positive sexual partner, or if they had bacterial sexually transmitted infection in the past 6 months, or history of inconsistent or no condom use with sexual partners. For people who inject drugs, if they have HIV positive injecting partner, or if they participate in sharing injection equipment, that kind of behavior will put them at risk of HIV, so they qualify for PrEP. Now, for clinical eligibility, there has to be a documented negative HIV antigen antibody test result within 1 week. So it could be in the past 7 days before initiating PrEP. This is important to exclude HIV because these regimens are incomplete full treatments of HIV. So if people do have underlying HIV infection, that will result in resistance. So it's important to rule out unidentified HIV infection. So we screen there has to be no signs and symptoms of acute HIV infection. And of course, depending on the agent, there should be no contraindications. And for oral regimens specifically, there are creatinine clearance cutoffs. So if the regimen includes TAF, creatinine clearance has to be at least 30 or higher. If it's TDF, creatinine clearance has to be at least 60 or higher. And these are for prevention only, for prophylaxis use. If TAF or TDF are used for treatment, these cutoffs do not apply. So refer to those cutoffs for treatment regimens. And there are no creatinine clearance cutoffs for cabotegravir and lenacapavir. Now let's take a look at the options. So in general, efficacy of PrEP, either oral or injectable, it is dependent on adherence to ensure that plasma drug levels reach a protective level, it's important to note that the time from initiation of PrEP to maximum protection against HIV infection is unknown. So when somebody initiates these, it's not clear if they have the protection immediately or, a few days later. But we do know from pharmacokinetic studies, specifically from Truvada, is that, we get enough concentrations of Truvada in different sites. So it really depends on the site. So if it's, for example, people who inject drugs, the site of infection will be blood. So some sources say it will take 7 days, others say 20 days. So it's safe to assume that somewhere, in the first, it will probably take around 2 to 3 weeks before this pre-exposure prophylaxis is fully effective in preventing HIV infection through blood. And that's 20 days in cervical-vaginal tissue. So for women, this makes a woman participating in vaginal intercourse. The cutoff is 20 days. For rectal tissue, which is the primary route for men having sex with men, as well as also for women, that could be the route of intercourse. So 7 days, and it's faster for rectal because these are oral regimens. So it goes through the mouth all the way through the colon. So it goes, because these are oral regimens, they go to the site that's of interest immediately, whereas for cervicovaginal tissue, it needs to be absorbed first and go into the blood, and then blood needs to go to the vaginal tissue and transfuse for this drug to achieve concentration. So it's longer, it takes longer to get enough concentrations in the vaginal tissue. And we don't have any data as far as penile tissue. Now, these are based on Truvada when it comes to Descovy, which was approved for PrEP in 2019. We don't really have the PK data, so it's not clear how long it will take. If we had to guess, it will probably be similar to Truvada, but the truth is that we just don't know. And as I mentioned before, Descovy has not been approved for heterosexual couples or people who inject drug. It just has not been studied. It has only been studied in MSM or transgender women. And of course, most recently, at the end of 2021, cabotegravir in long-acting was approved for pre-exposure prophylaxis. Now, because so here's the package, and it has one vial, so it only has cabotegravir in it. It does not have relpevirine. So relpevirine is only used with this when you have the full treatment. But for pre-exposure prophylaxis, it's only cabotegravir, so only one agent. Now, because it's a long-acting, it takes several weeks for the body to clear this. Some patients may have concerns about tolerability. So if somebody was to have a bad adverse effect to this, they will have that for several weeks. So there is an optional short-acting oral cabotegravir that they can try for 4 weeks just to make sure they don't have any adverse effects. But this is optional because it is extremely rare for patients to have intolerable adverse reactions to this drug, so that's optional. Just like the oral option, the time from initiation of PrEP with this regimen to protection is unknown, so it's not clear how long it would take. Now, because of the long half-life, there is this long tail of gradually declining drug levels. So if somebody wants to come off PrEP, then because of the long half-life, they're going to have the drug in their system for a long time, including once it goes subtherapeutic, they will have that subtherapeutic levels for a long time. So if they happen to get HIV infection during that time, they are at high risk of developing drug resistance. So that makes it tricky. When somebody discontinues this, it's probably a good idea to go on oral PrEP if they are to have some exposure to HIV. Of course, if somebody knows for sure they're not going to have exposure to HIV, it's not going to be an issue just discontinuing this. Now let's take a look at lenacapavir. Yeztugo is the brand name for the formulation that's used for pre-exposure prophylaxis specifically, not for treatment. and it was approved in 2025. Now, this one is required to have 2 days of oral regimen as a loading dose, so 600 milligram oral lenacapavir on day 1 and day 2, and then this is an injection every 6 months. Now, the time from initiation of PrEP to maximal protection against HIV infection is likely 2 hours after the dose on day 2, so that's why the loading dose is provided to increase the time to maximum benefit. Whereas if the 2 oral doses are skipped, it will take 21 to 28 days, so essentially about a month, 3 to 4 weeks, until patients have protections. Thereafter, there is no need for oral regimen, so it's an injection, subcutaneous injection every 6 months. Now, because this is a long-acting agent, when discontinued, medication levels in the body decline over 18 months, starting 6 months after the last injection, which we call the long tail. And this is the significance of the long tail. So here on the y-axis, we're looking at drug concentration, and on the x-axis, we're looking at time. And imagine the blue line is an oral regimen for PrEP. So people take an oral, you have a peak, and then it's time for the next one. So you get multiple. Occasionally, if somebody skips a dose, the levels will go below the therapeutic levels, and it will go into the resistance zone. So resistance zone is essentially where the drug still exists. So we have some sub-therapeutic levels of the drug where the virus can actually develop resistance to it. And then if the patient takes it again, it will go above. And then if you discontinue the regimen because there's no need for it or for other reasons, there will be a small window for the levels to be in the resistance zone until it becomes undetectable. Now, with long-acting agents, once the patient discontinues it, the level goes below therapeutic level, and then it will stay in the resistance zone for a very long time. And during this long time, if the patient no longer has a need for pre-exposure prophylaxis because the risk of exposure is no longer there, this is not a concern. But if the risk of exposure is there, and this is a patient who's non-adherent, this really exposes patients for a very long time to develop resistance, and that becomes problematic with these agents. Now let's look at the follow-up for monitoring. So it is recommended that for all patients to at least every 3 months to get the HIV testing, as I mentioned before, to make sure that if they test positive, they need to transition. This is primarily based on oral PrEP, so we're talking about Truvada and Descovy. So if they do test positive, they need to be transitions to ART, and the HIV testing is a combination of antigen antibody and RNA assay, which I'll explain shortly. And then because of the risk factors for getting HIV and STIs are the same, so bacterial STI screening is also recommended. Now it's recommended more frequently for MSM and transgender women, so every 3 months, whereas for everybody else, bacterial STI screening is recommended every 6 months. And of course, as part of these every 3 months, it's important to assess signs and symptoms of acute HIV, as well as side effect assessment, so we can manage side effects to improve adherence. There could be other reasons for non-adherence, so it's important to do a full adherence assessment and provide support to patients. And depending on what risk factors they have, it's also important to continue to assess those risk factors, because if they don't have those risk factors, then they may not need to be on PrEP continuously. So if somebody doesn't have those risky behaviors anymore, they can come off PrEP. And for people who inject drug, it is important to assess access to clean needles and syringe, and in fact it would be important to provide to them clean needles and syringes, because if we don't, what ends up happening is that patients just share needles or use dirty needles that they find at various places. Of course, for women, it's important to do pregnancy tests. Now, if somebody is receiving tenofovir-based PrEP, it's important to assess renal function. If they are aged 50 years or older, or at baseline their creatinine count is less than 90, the renal function needs to be assessed every 6 months. Otherwise, if somebody is younger than 50 or if their renal function is greater than 90 at baseline, they can just be assessed every 12 months for renal function. And then every 12 months also it is important to assess weight and lipid panel if they are receiving TAF. So TAF only, TAF specifically is associated with weight gain and dyslipidemia. So that does not apply to TDF. And lastly, evaluate the need to continue PrEP annually. For the injectable cabotegravir, which is injected every 8 weeks or every 2 months, again, at 1 month after the first injections, it's important to get HIV testing, as well as checking for acute HIV and assess risky behaviors. And then every 2 months, and the reason these are shorter follow-ups is because they match the time that the patient has to come back to the clinic to get the injections. So essentially, these are every 2-month injections. So if the patient is coming back to the clinic to get the injections, then there's opportunity to do HIV testing and make sure that they have access to clean needles and all the other things that we need to do. So at every 4 months, it's important to get STI screening for MSM. Every 6 months, STI screening for everybody else. Every 12 months, assess desire to continue injections. So in other words, PrEP is kind of like birth control. So, people don't need to be on it for forever, but as long as they have risk of being exposed, the same way that, for birth control, as long as somebody doesn't want to be pregnant, they receive birth control, but it's not for life. The same applies to PrEP. As long as somebody is at risk of being exposed to HIV, they can be on PrEP. But if those risk factors go away, for example, let's say they stop injecting drug, or if they change their partner and they're no longer being exposed to a sexual partner with HIV, then they no longer need to be on PrEP. And that's something that needs to be assessed every 12 months. Now, the monitoring for lenacapavir is more straightforward. This is every 6 months injection. So most of the monitoring is every 6 months. Now, it is recommended to consider an initial follow-up at 1 month. So it will essentially be everything you do at 6 months, do it at 1 month. But again, that's optional depending on a case-by-case basis. So every 6 months, again, you want to test for HIV, assess for adverse reactions, including injection site reactions, assess signs and symptoms of acute HIV, because if the patient does develop HIV, they need to be switched to full treatment. Identify significant drug interactions or contraindications, screen for STIs, and consider doxycycline post-exposure prophylaxis when indicated for sexually transmitted infections. Evaluate social support and other care needs, and risky behavior assessment and support. Access to clean needles and syringes and drug treatment services for people who inject drugs. Assess desire to continue injection for pre-exposure prophylaxis. And when discontinuing lenacapavir, re-educate patients about the risks during declining lenacapavir levels during the long tail. Assess ongoing HIV risk and prevention plans. And if PrEP is indicated, but the patient no longer wants the injection, prescribe daily oral pre-exposure prophylaxis within 6 months after the last injection. The last injection will continue to protect the patient for 6 more months. Now, when it comes to adherence assessment and support, there are several approaches that can be effective. One is educating patients about their medications, helping them anticipate and manage side effects, asking about adherence success and issues at follow-up visits. So for example, you can say something like, many people find it difficult to take a medicine every day. Thinking about the last week, on how many days have you not taken your medicine? So this is asking, well, first of all, you make sure that the patient feels safe. So by making it, non-judgmental, that this can happen to a lot of people. And then secondly, asking an open-ended question so the patient can open up about their adherence. And helping them establish dosing routines that mesh with their work and social schedules. And providing a reminder system and tools. Addressing financial substance use disorder or mental health needs that may impede adherence, and facilitating social support. And of course, one counseling point is patients should be told to take a single missed dose as soon as they remember it, unless it is almost time for the next dose. If it's time for the next dose, they can just skip it and continue the regular dosing schedule. Please pause this video and review these key components of oral medication adherence counseling. Lastly, the Senate Bill 159 in California came into effect in July of 2020, and this is important because this new addition to the bill essentially lets a pharmacist furnish or dispense HIV PrEP as well as HIV post-exposure prophylaxis. In this part, I'm going to focus on the pre-exposure prophylaxis. And the bill says a pharmacist shall complete a training program approved by the board, which we provide that here in the school through this course. And then a pharmacist shall furnish at least a 30-day supply and up to a 60-day supply of PrEP if all of the following conditions are met. Now, this is slightly different than the guideline, because the guideline, which is in general for physicians, the limit is up to 90 days. For a pharmacist is up to 60-day supply, but at least a 30-day supply until, and this is essentially to link them to care so they can follow up with a primary care physician. Now, it is important before a pharmacist can furnish this to make sure the patient is HIV negative. And this must be based on blood, not the oral saliva test. And it must be within the past 7 days. No self-reported signs or symptoms of acute infection. No currently taking contraindicated medications. And the pharmacist provides counseling to the patient on the ongoing use of PrEP, which may include education about side effects, safety during pregnancy and breastfeeding, adherence to recommended dosing, and importance of timely testing and treatment as applicable for HIV, renal function, Hep B, Hep C, STIs, and pregnancy for individuals of childbearing capacity. And the pharmacist shall notify the patient that the patient must be seen by a primary care provider to receive subsequent prescriptions for PrEP, and that the pharmacist may not furnish a 60-day supply of PrEP to a single patient more than once every 2 years. And the pharmacist initiating or furnishing PrEP shall not permit the person to whom the drug is furnished to waive the consultation required by the board. So they cannot waive all of this information. You are required to provide all this education to the patient.